Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Usually when we talk about a surgical procedure, there's this expectation of mechanical predictability.
Right, like carpentry.
Exactly. You have a structural problem, you go in, you physically reinforce the weak point with some hardware or sutures, and the job is done. The anatomy complies with your repair.
And that is the assumption that so many carry into the operating room. You see a defect, you close it, A plus B equals C.
But then you step into the world of foregut surgery.
Yeah, specifically the gastroesophageal junction.
Right, and that predictability just completely vanishes. You're operating on a moving target at the intersection of two distinct pressure zones, and the tissue itself is notoriously unforgiving.
It really is.
So, welcome to today's deep dive. We are speaking directly to you, the surgeons, the residents, and all the medical professionals joining us.
Glad to have you with us.
And because we are diving deep into highly specific surgical techniques and clinical guidelines today, we need to establish upfront that this content is strictly for reference and educational purposes only.
Exactly. You must always follow your local guidelines, your hospital protocols, and of course, your own clinical judgment in your practice.
The human body doesn't read the textbooks, so local context and individual patient anatomy dictate the actual reality in the OR.
They dictate everything.
Today is a masterclass in the Nissen Fundoplication. We've pulled together a massive stack of surgical texts, clinical guidelines, and operative analyses. And the central thesis that draws all of these sources is that this standard anti-reflux operation is fundamentally intolerant of poor anatomy and tension.
It is entirely unforgiving.
Right. We aren't just tying a knot around a tube here.
No, the procedure demands a really specific philosophical approach. The actual 360-degree fundoplication, that's just the final product.
Yeah.
The actual success of the operation relies entirely on meticulous tissue handling, fiercely protecting the vagus nerves, and treating the diaphragmatic crura with absolute respect at every single step.
Because forcing the anatomy to do something it doesn't want to do
will inevitably punish the patient with severe complications later.
Okay, let's unpack this. Because before we can build the perfect wrap, we have to create the perfect environment, right? The physical setup of the room and the patient dictates the success of the entire dissection.
Absolutely. The standard approach requires placing the patient in the supine French, or the split leg position.
Right, with their arms tucked.
Tucked tight, yeah. And utilizing a steep reverse Trendelenburg tilt. The surgeon actually stands right between the patient's legs.
Which feels unusual if you're not used to foregut surgery.
It does, but this alignment is crucial because it gives you a direct, straight-line view straight up toward the esophageal hiatus. And that steep reverse Trendelenburg tilt, well, it uses gravity as your primary surgical assistant.
Okay, that's a great way to put it.
Yeah, it allows the transverse colon, the omentum, and the small bowel to just simply fall away into the lower pelvis.
Right, getting them completely out of your way.
Exactly. It brings the stomach and the hiatus right into your central field of view, while simultaneously reducing venous congestion in the operative field.
So you're basically building a runway.
Mm-hmm.
And then you have the port placement. We're typically looking at a 5-port setup, right?
Okay.
You have the camera port, usually above the umbilicus, your left and right, upper quadrant working ports, an epigastric port for the liver retractor, and an assistant port. The surgical texts make a massive point for newer surgeons to completely standardize this setup.
It has to be muscle memory.
Yeah, I view this like an airline pilot's pre-flight checklist. If your physical foundation, where your hands rest, the angle of your instruments, the geometry of your triangulation, if that is identical every single time, you free up an immense amount of mental bandwidth.
That's spot on. Triangulation is the fundamental geometry of laparoscopic surgery. If your ports are placed poorly, your instruments will constantly cross like swords.
Which is incredibly frustrating.
It makes precise suturing nearly impossible. And you aren't fighting your instruments if you standardize, which means you have the cognitive reserve to handle mid-flight anatomical anomalies.
Because anomalies appear before you even start cutting.
Oh, absolutely. Take the epigastric port, for instance, which is where you deploy the liver retractor. You need secure, gentle retraction of the left lobe of the liver to expose the hiatus beneath it.
And the liver capsule is incredibly delicate.
It's like wet tissue paper. If the retractor is deployed clumsily or positioned with too much downward force, the metal will tear right through the hepatic parenchyma.
Wow.
You're looking at a segment IV liver laceration, which bleeds profusely before the actual operation has even commenced.
So navigating the setup safely is paramount. That brings us to the initial exposure. We're staring at the lesser omentum, specifically the gastrohepatic ligament.
Right.
This is that thin membrane connecting the liver to the lesser curve of the stomach.
Yeah.
And we have to open this to expose the right crust of the diaphragm and the hiatus.
You want to incise the avascular translucent portion of that ligament, the pars flaccida, just to the right of the esophagus. But the immediate hazard here is an aberrant left hepatic artery.
Right. The anatomy texts flag this constantly.
Because in a significant percentage of patients, the left lobe of the liver receives its primary or accessory blood supply not from the proper hepatic artery, but from a branch off the left gastric artery.
And this aberrant vessel runs straight through the exact ligament you were trying to cut.
Straight through.
So if you just blindly slice through that tissue, you sever the blood supply to the left lobe of the liver.
Yeah. Now, the liver is somewhat forgiving due to dual blood supply from the portal vein, but sacrificing a true replaced left hepatic artery can lead to left lobe ischemia or outright necrosis.
Which is a disaster.
You have to map the vasculature visually before applying energy.
Well, let's talk about the energy devices, actually.
Yeah.
We are using diathermy or ultrasonic shears to clear tissue and identify the right crust and the anterior vagus nerve, which runs down the front of the esophagus.
Right.
And this is where the texts issue a major warning about thermal spread.
What's fascinating here is how insidious thermal energy actually is. Energy devices clear tissue efficiently, but the heat they generate radiates outward.
Right.
If you activate an ultrasonic device or monopolar electrocautery too close to the anterior vagus nerve, the lateral thermal spread will cause an invisible injury.
Invisible, like you literally can't see it in the OR.
Exactly. Intraoperatively, the nerve's outer sheath, the epineurium, it looks entirely intact. Structurally, it seems totally fine. But microscopically, the heat has destroyed the axoplasm or the myelin within.
Wow.
And months down the line, this patient develops insidious, delayed gastric dysmotility. Their stomach simply stops emptying properly because the parasympathetic innervation driving peristalsis has basically been cooked.
That's terrifying. If thermal injury is essentially invisible in the moment, how do we best mitigate that risk while still getting the exposure we need?
The strategy relies entirely on traction and countertraction to exploit the natural adventitial tissue planes. You never apply energy directly on or adjacent to the esophagus or the nerve. Instead, you and your assistant pull the tissues apart, creating this sort of tent of a vascular tissue.
A physical separation.
Right. You apply short, disciplined bursts of energy strictly to those stretched translucent bands far away from the vital structures. It requires immense patience.
So now that we've safely cleared the landmines in our visual field, we face the next physical barrier, which is the tension of the esophagus itself.
Yes, the 2 to 3 centimeter rule.
Right. We have to pull the esophagus down from the chest cavity and secure the opening it passes through. And the operative guidelines emphasize this metric as non-negotiable.
Achieving at least 2 to 3 centimeters of intra-abdominal esophagus is the absolute cornerstone of a successful fundoplication.
And how do you actually get that length?
To get this, you must perform a circumferential mobilization of the distal esophagus high up into the posterior mediastinum. You incise the phrenoesophageal membrane.
That's the tissue connecting the esophagus to the diaphragm.
Exactly. And you physically enter the chest cavity from below. You dissect all the way around the esophagus, developing a retroesophageal window.
And a critical phrase in the literature is that this 2 to 3 centimeters must be lying naturally below the hiatus without traction.
Right, without traction. That's the key.
You cannot just pull it down with a grasper and hold it there.
Yeah.
Because the physical dynamics of the human body make tension a guaranteed failure.
It's pure physics.
The thoracic cavity, where the lungs sit, operates under constant negative pressure to draw air in. Meanwhile, the abdominal cavity operates under positive pressure.
And the diaphragm acts as the barrier between these two pressure zones. If that intra-abdominal segment of the esophagus is under longitudinal tension, say, because you didn't mobilize it high enough into the chest,
Right.
the physics of the body will take over the moment the patient wakes up. Every single time they take a breath, the negative pressure of the thorax is going to actively suck that stomach back up through the hiatus.
Which leads to early rat migration and recurrent reflux. But what happens if you dissect high into the mediastinum? You clear all the attachments, and the esophagus is still too short. Like the tension is just inherent to the patient's anatomy due to years of chronic acid damage shrinking that tissue.
So sorry for the interruption, but this is important. We need your support to help us grow, reach more surgeons, and keep delivering cutting-edge surgical content. Press the support button and donate now if you like what we do. Let's get back to the podcast.
That's a very difficult situation. In cases of a true fibrotic short esophagus, you have to surgically lengthen the tube.
Okay.
This involves a maneuver called a collis gastroplasty. You essentially fire a linear stapler down the upper stomach parallel to the lesser curve, creating a neo-esophagus out of stomach tissue to gain that necessary 2 to 3 centimeters of length.
Oh.
Yeah, it transforms a standard Nissen into a highly advanced specialist-level procedure.
And while we were working up inside the mediastinum, hugging the esophageal wall to get this length, we're operating in a very confined tunnel. I mean, the pleura of the lungs and the pericardial sac surrounding the heart are literally millimeters away.
You have to be incredibly precise. Straying even slightly lateral during this mediastinal dissection risks breaching the thin pleural membrane. A pneumothorax in a patient under positive pressure ventilation will immediately compromise their respiratory mechanics.
Right.
You also have to guard against devascularizing the esophagus itself. You need to mobilize it by dividing the fibrous attachments. But if you aggressively strip away all the surrounding adventitia, you destroy the fragile capillary network feeding the esophageal wall.
Which makes it highly prone to delayed perforation or stricture formation.
Exactly. A devascularized esophagus is a ticking time bomb.
Okay, so we have our length. The esophagus is resting comfortably in the abdomen. The next structural requirement is rebuilding the hiatus, the posterior cruroplasty.
Yes.
Because the esophagus passes through this teardrop-shaped opening formed by the right and left crura of the diaphragm. And over time, in reflux patients, this opening becomes stretched and totally incompetent.
So we have to bring those muscular pillars back together behind the esophagus using 2 to 3 interrupted, non-absorbable sutures.
But you cannot simply sew the hole shut.
No, definitely not. Before you place a single suture, anesthesia must pass a large 52 to 60 French bougie, basically a thick, flexible dilator, down the patient's mouth, through the esophagus, and into the stomach.
I picture the cruroplasty exactly like a tailor fitting a collar for a dress shirt. If you measure and sew that collar tightly without the person's neck actually inside it, you are guaranteed to choke them.
That's a perfect analogy. The bougie acts as the physical stand-in for a large bolus of food. If you close the crura without it, you will inevitably create an overtight hiatus.
And the patient will wake up unable to swallow solid food, post-operative dysphagia.
Exactly. You want the reconstructed hiatus to be snug around the bougie, but not strangling it. And the specific tissue you're driving your needle through dictates the longevity of this repair.
Right.
The crura are essentially skeletal muscle bordered by a tendinous edge. In older patients, or those with massive hiatal hernias, this muscle is incredibly friable. I mean, it literally has the consistency of wet cardboard.
So if you just take a shallow bite of that tendinous edge, the physics of a simple cough, which, violently spikes intra-abdominal pressure, that cough will cause the suture to act like a wire cheese cutter.
It'll slice right through the tissue.
Just through it.
To distribute that tension, you have to take deep, generous bites into the belly of the crural muscle itself. Sometimes surgeons will even use small Teflon pledgets.
Like little pads.
Yeah, little pads to buttress the sutures and prevent them from pulling through those muscle fibers.
And this brings up the great debate regarding massive paraesophageal hernias, where the hiatal defect is so enormous that even deep bites won't bring the crura together without immense tension. The texts discuss using synthetic or biologic mesh to bridge the gap or reinforce the repair.
It's a hugely debated topic. Mesh introduces a severe long-term hazard. Placing a synthetic mesh directly adjacent to the esophagus means that, over years, the constant mechanical friction of swallowing can cause the mesh to literally erode through the esophageal wall. It is a devastating complication. Using mesh is always a complex intraoperative judgment call, balancing the immediate risk of hernia recurrence against that long-term risk of erosion.
Okay, so the runway is built, the hiatus is secured, the esophagus is lying tension-free. We transition now to the star of the show, the defining mechanism of the surgery, mobilizing the fundus of the stomach and constructing the 360-degree wrap to act as the new anti-reflux valve.
Right.
The first physical step is entering the lesser sac behind the stomach.
You do this by dividing the filmy adhesions between the upper stomach and the surrounding organs, ensuring the posterior wall of the stomach is completely free.
Here's where it gets really interesting. This leads us straight into a massive controversy in the surgical literature: the division of the short gastric vessels.
Ah, yes.
These are the small arteries and veins connecting the upper left side of the stomach, the greater curve, to the spleen. Some experts argue you must divide them routinely to free up the stomach, but others say it's strictly optional.
It's highly debated.
But from a purely mechanical standpoint, if a tension-free wrap is the absolute ultimate goal of this surgery, dividing those vessels physically frees the fundus? Why wouldn't you divide them every single time?
It illustrates the constant trade-offs required in tissue manipulation. Dividing the short gastrix definitely gives the fundus more mobility. But the stomach relies on a really delicate vascular arcade. Over-enthusiastic division can devascularize the very portion of the stomach you intend to use for the wrap.
Right.
Furthermore, the dissection puts your instruments directly against the splenic hilum.
And the spleen is notoriously fragile.
Extremely. The connective tissue anchoring the stomach to the spleen is incredibly short. If you apply too much traction, you can easily avulse a capsular vessel, causing a splenic tear.
Which is an immediate problem.
The bleeding is immediate and profound, often requiring an unplanned splenectomy. And when you look at the long-term outcome data, routine division of these vessels does not universally reduce the rates of long-term dysphagia or reflex recurrence compared to just leaving them intact.
So the approach really has to be tailored to the tissue you're feeling in the room. You do a drop test, right?
Exactly.
Pull the fundus over, let it go, and see where it lies naturally. If it swings easily behind the esophagus without fighting you, leave the vessels alone. If there's mechanical resistance, you carefully divide the short gastrix, staying meticulously close to the stomach wall to avoid the spleen.
Once the fundus is adequately mobilized, you create a window behind the distal esophagus, obviously double-checking that the posterior vagus nerve is safely out of the way.
Right.
You pass a blunt grasper gently through that window from left to right, grab the posterior wall of the fundus, and smoothly draw it behind the esophagus.
So now we're actually constructing the wrap.
Yeah.
And we need to understand the physics of a check valve here. In plumbing, a check valve yields to forward pressure but snaps shut against backflow. The Nissen wrap functions exactly the same way.
It has to.
It needs to be soft and pliable enough to yield to the downward 50 millimeters of mercury pressure from a normal peristaltic swallow, but structured enough to block the upward 200 millimeters of mercury pressure spike from the stomach during a cough.
And the literature dictates highly specific dimensions to achieve this Goldilocks valve. The defining hallmark of a modern Nissen is that it must be short. We are aiming for a wrap length of only 1.5 to 2 centimeters.
That's tiny.
It is. You use 2 or 3 interrupted non-absorbable sutures to bring the anterior and posterior walls of the fundus together around the front of the esophagus.
And a crucial mechanical detail from the guidelines: that first suture isn't just stomach to stomach. It actually incorporates a seromuscular bite of the esophagus itself right in the middle.
This anchors the wrap to the esophageal wall. It essentially prevents the stomach from telescoping or sliding down through the wrap over time.
We need to run through the specific physical red flags during construction. The texts frequently mention performing a shoeshine maneuver before tying the knots.
Right, you take the 2 edges of the fundus and literally pull them back and forth around the esophagus, like shining a shoe. This ensures the gastric serosa, the smooth outer lining of the stomach, is facing outwards and guarantees there's absolutely no twisting or spiraling of the tissue.
And you also must ensure you are strictly using the fundus.
Right.
Why does the specific region of the stomach matter so much?
Because the fundus is the uppermost part of the stomach. Its musculature is relatively thin and highly distensible. It functions naturally as a reservoir. If you mistakenly pull the gastric body or the antrum up to create the wrap, you're using thick, highly active muscle designed for grinding food.
Oh, I see.
Instead of a soft, yielding valve, you create a rigid, spastic clamp around the esophagus.
Which explains why the operative manuals emphasize the word floppy constantly.
A floppy valve is the only acceptable outcome. With that massive bougie still in place inside the esophagus, the completed wrap should just gently rest against it. There can be absolutely no blanching or whitening of the stomach tissue, which would indicate ischemia from tension. You should be able to easily pass a blunt instrument between the wrap and the esophagus.
The physics of Poiseuille's law apply perfectly here. Resistance to flow through a tube increases dramatically based on the length of the narrowed segment. If you build a wrap that is 4 centimeters long instead of 2 centimeters, you exponentially increase the resistance the esophagus must overcome to push food through.
Which is terrible for the patient.
An overlong wrap leads to severe dysphagia and is highly prone to herniating back up into the chest.
Conversely, an over-tight wrap creates a mechanical obstruction. A floppy, short wrap is the absolute sweet spot.
But, a beautifully constructed floppy 2-centimeter wrap is functionally useless if it migrates out of place the minute the patient is wheeled into the recovery room. We have to anchor it. This is the gastropexy phase.
Fixation ensures durability. You take an additional suture or two and anchor the completed wrap to the right or left diaphragmatic crus. This physically tethers the wrap within the abdominal cavity, preventing caudal slip.
Which is when the wrap slides down the stomach.
Exactly, or cranial migration back into the hiatus.
So we transition to our final checks. We confirm our 2 to 3 centimeters of intra-abdominal esophagus. We have anesthesia, carefully withdraw the bougie. We suction the stomach to ensure it's completely decompressed. And we meticulously inspect the sophrenic space and the splenic hilum for any signs of bleeding.
Because once the patient leaves the OR, the physiological consequences of our technical choices become their daily reality.
Yeah.
A surgeon's handling of the tissue echoes for years in the patient's quality of life. We have to separate expected physiological adjustments from true mechanical complications. When the patient wakes up, they will likely experience mild dysphagia, some early satiety or bloating, and mild chest discomfort.
Which is normal.
Yes, this is just due to localized tissue edema around the hiatus. As the swelling subsides over a few weeks, the symptoms resolve.
But then there are the severe complications that demand immediate recognition. Let's look at missed bleeding.
If we connect this to the bigger picture, if a small arterial bleeder from the short gastric pedicles or the crural muscle retracts and stops bleeding transiently while the abdomen is pressurized by the laparoscopy gas, you might miss it entirely.
Wow, because the gas pressure is literally holding it shut.
Exactly. But once the gas is removed, it bleeds freely into the subphrenic space. Post-operatively, this localized hematoma presents as referred shoulder pain, unexplained fever, and tachycardia. It's basically a brewing infection or abscess.
One of the most miserable complications detailed in the literature is gas bloat syndrome.
It is awful. The physiology of normal belching requires transient relaxations of the lower esophageal sphincter. A Nissen Fundoplication physically alters this dynamic.
Right.
In gas bloat syndrome, the patient physically loses the ability to belch or vomit. Air swallowed during eating or talking fills the stomach, and it has absolutely nowhere to go. The stomach distends painfully.
And the mechanics behind this point back to 2 specific surgical errors. Either the wrap was built too tightly, creating a permanent mechanical obstruction that air just cannot push past, or the surgeon damaged the vagus nerve fibers, destroying the fundic innervation required to initiate the belching reflex.
This leads directly into the importance of preoperative patient selection. Pre-existing esophageal motility disorders or severe preoperative bloating are glaring red flags. They are relative contraindications for a full 360-degree Nissen.
Because if a patient's esophagus already lacks the peristaltic power to push food down, placing a full 360-degree valve at the bottom of it is a recipe for complete obstruction.
In those scenarios, you have to pivot your operative plan based on the patient's specific physiology. You perform a partial wrap, such as a toupet fundoplication.
So instead of going all the way around, a toupet is a 270-degree posterior wrap. You pull the fundus behind the esophagus, but you anchor the edges to the right and left sides of the anterior esophagus, leaving the front exposed.
This creates a competent anti-reflux barrier, but leaves the anterior wall of the esophagus, and crucially the anterior vagus nerve, completely free. It yields much more easily to a weaker esophageal swallow, dramatically reducing the risk of postoperative dysphagia in patients with poor motility.
So what does this all mean? To synthesize the mechanics of this entire procedure, the ultimate prophylactic against almost every major postoperative complication, from dysphagia to herniation to splenic bleeding to gas bloat, is a technically pristine, tension-free, visually floppy wrap anchored securely below a properly sized hiatus.
Perfectly said. You respect the physics of the anatomy, and the anatomy will support the repair.
I love that.
But I do want to leave you with a concept to consider regarding the future of this field. We spent this time discussing how brutally unforgiving foregut surgery is of poor anatomy, and how heavily success relies on a surgeon's tactile feedback in the room. Feeling the tension of the fundus, judging the friability of the crura.
Right, it's very manual.
Looking forward, we have to ask how advanced dynamic 3D preoperative imaging will alter this landscape.
Oh, wow. Moving from a reactive surgery to a predictive one.
Exactly. Imagine a protocol where high-resolution imaging simulates the specific pressure dynamics of a patient's abdomen and chest before they even reach the OR. It could calculate their unique tissue elasticity and predict whether their specific anatomy is mechanically suited to handle a full 360-degree wrap.
Or if the sheer physical resistance of their tissues mandates a partial wrap instead.
Right. It would completely remove the intraoperative guesswork and fundamentally revolutionize patient selection.
What a fascinating mechanical evolution. The architecture of the foregut is messy, it's dynamic, and completely unforgiving. But with an uncompromising respect for the tissue planes and the underlying physics, it can be reconstructed beautifully.
It really can.
We are wrapping up this deep dive, but we want to thank you for joining us. If you like this content, then please do not forget to share it with at least one of your colleagues or friends to spread the word.
We really appreciate it.
Also, be sure to check out our YouTube and other social media pages. And definitely do check out our previous season and past episodes, which feature some very relevant, deeply technical medical topics that we know will aid your clinical understanding. See you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.